Thank you for that nice long introduction. So I'm down at Banner University Medical Center, Phoenix, down at what everyone always used to know as Good Sam downtown. But we have a satellite office in South Scottsdale now too, or like Osborne area. So that's a lot more accessible for a lot of patients from the East Valley. And I have a real unique practice in that, I did general OBGYN and delivered babies for about 15 years, and then decided to kind of really flip the switch and go to UCLA and do this fellowship and then get certified through ASECT as a sexuality counselor. So I have a real unique specialty practice now dealing with sexual concerns for women, vulvar disorders, and menopause medicine. So that keeps me busy enough. But I'm here today to talk specifically about that span of time after delivering a baby. Everybody's, excited to welcome a new baby into the family, whether it's the first one or the second one or subsequent ones. It's always an exciting thing to anticipate. But what happens when our sex life goes from great to disrupted? And there's always some degree of disruption that occurs because, adjustment is always, we don't have life without adjustment and phases. But it's when this adjustment takes a wrong turn and doesn't course correct that we often need to get some help. Can everybody see this screen okay? I feel like everything's so spread wide, but hopefully you can follow. And so what happens when this disruption becomes prolonged is we get distant and resentful, and that's no good at all for a relationship. So just to give you some norms, because, we all have a sense for what is normal. Maybe we think how frequent we had sex before we started having a family was normal, but I think it's helpful in terms of like the general population, what is going on out there. And so this study kind of characterizes, this little graph shows that prior to pregnancy, 80% of women are having sexual activity, penetrative intercourse, at least 5 or more times a month. That's that dark bar. Then you look at postpartum, the first year, and that decreases to only 40% of those women are having sexual activity 5 or more times a month. And instead, it's kind of flipped, and the light-colored bar indicates the frequency goes down to about 1 to 4 times a month. So about, maybe half. It's kind of hard to see on this TV monitor, but this is another survey they did for using data from about 1,200 women that they surveyed. Again, to try to quantify. And of course, in the dark red dark red is before the baby, and in the light pink is after the baby. And then on the bottom row is the younger women, 18 to 24, middle is 25 to 29-year-olds, and the top is 30 to 34-year-olds. So we see average days per week of sex, the younger you are, the more likely there are to be more, so like 4 in the young span. And then as we get into the 30 to 34-year-old group, it's twice a week. But then after the baby, all 3 groups kind of normalize to about once a week. So it just kind of gives you a frame of reference to measure yourself from. I read a study a few years ago that they tried to quantify how often men think about sex and how often women think about sex. Because, the stereotype is that men are always thinking about sex and women not so much. So they had people wear clickers on their waist so that anytime a thought came that had to do with sex, they would click. And what the data showed was that men thought about sex on average 34 times an hour, and women were 19, so more than you'd think, right? But the twist of that was they were also supposed to track whenever they had a thought about, I'm hungry or I'm sleepy. And men also thought about those things equal with sex. So it's not just that sex is on their mind, but sleep and eating are too. It's just kind of a fun way to quantify statistics in terms of the genders. So they've also quantified the value of healthy sex. It turns out it does have a financial value. It's vital in the happiness equation, as they put it. What they found was that if you can increase the frequency of sex from once a month to once a week, that gives the couple a happiness factor that's equal to getting a $50,000 a year raise. So that would make you pretty happy, right? Other happiness factors that I just think are fun to throw in there, since we're talking about relationships and families and everything. We're happiest when we spend at least 6 hours a day in some form of socializing. I mean, we're social animals. We're not supposed to live in isolation. The number of friends it takes to significantly boost your well-being looks to be about 10. A circle of at least 10 friends that you can interact with puts you in that level of feeling accepted and cared for and happy. Turns out happy couples have a 5-to-1 ratio of good exchanges to negative ones. So for every criticism, you have 5 appreciations or gratitudes. That same statistic said couples who eventually divorced, the ratio changes to 0.8 to 1, so almost a 1-to-1. Like for everything I like, I also don't like. So it's good to keep our ratio in that more appreciative category with our significant others. Having sex once a week makes you 44% happier. If you can increase that to twice a week, to 55% happier. Kind of goes along with everything I've said so far. And then we can have a great influence on our spouse. If we can help make our spouse happy or your spouse gets happy, your own chance of happiness increases by 25%. So it just shows the positive effect we can have on each other. And that's really important as we go through this new experience of new babies, new families, growing families, to always remember how can we impact our intimate family members, our partners, to increase everybody's happiness. There are some benefits to intimacy. It's not just all about we have to do this just to make a baby. It's also good for us. It's good for our minds. It's good for our bodies. Of course, we increase our circulation and move blood around, strengthen muscles in that way, especially the pelvic floor muscles, which I'll talk about in a few moments. Our hormone and neurochemical levels change when we're having good sexual activity. We have better mood, and our bodies produce more IgA, which helps us with our immune function. We have less viral colds and flu and such because we have better immunity. Helps our stress, and really helps that relationship satisfaction. It's hard to keep that connection without some form of intimacy going on. And then it's really good for our self-esteem and our well-being. And on that note, the well-being part, there really have been identified 5 core human drives, and pleasure is one of those. And part of pleasure is intimacy and relating with that significant other. It's right up there with, acquiring, learning, defending, bonding, and pleasure. And it's not all about sex, but so much about sexual intimacy I consider really a vital sign for physical function, for mental function, emotional well-being. I mean, if you have deficits in that area, it's going to have its tendrils affecting everywhere. So it's important to get this balanced out. There's certain components that we look at to evaluate, what is healthy sex. Of course, in the physical realm, you have to have desire for the person. You have to have mechanisms of arousal. You have to be able to have orgasm. And then on the more esoteric side, It's emotional intimacy. It's appropriate sexual stimulation. You have to be turned on. And then the relationship has to be working for everything to fit together. It's amazing that it all really does work well as often as it does when you see how complicated the sexual response is. And so it's no wonder why one thing that goes awry can affect the whole process. So it's important to know this and these, important components. Of course, we have to have genital blood flow being reflexively pulled into the important areas, creating that tumescence, the engorgement of the labia and vaginal walls and clitoris. Release of lubricating secretions needs to happen, and of course that's so affected by hormone changes. There's at least 4 nerve pathways, separate nerve pathways that serve the female genitalia and the sexual response. So we do have a lot of overlap and redundancy in those areas, which is good. It's why women who've suffered spinal cord injury can still have orgasm much of the time because they learn to just capitalize on one of those other nerve systems that doesn't go through the spine. So it's great we have a lot of redundancy and backup methods to develop when we need to. And then we have to have intact central neuroendocrine mechanisms. Those are the brain chemicals that are produced in response to arousal or desire, or that then feedback loop and create more desire. And then for good satisfying orgasms, the pelvic floor muscles need to be able to respond and contract. And all of these things need to work together like a well-tuned machine to function well. And so that's where I come in with, we're still on the kind of the pioneer frontier in sexual medicine. A lot of discoveries every year are being made, new techniques, new evaluation techniques, new questionnaire tools, and even new medicines are coming out to help us with this. But we still have a long way to go. So the kind of the break point where it turns from, it's an adjustment, sure, things are different than they were before, and but they're going to, course correct and get back to normal. If that hasn't happened by 6 months, that's kind of the break point of, wow, we need to get some help and reel this in and do something, because past 6 months, it just gets more and more difficult to turn things around. Some barriers to resuming sexual activity that often do persist past 6 months. The first one is body image. It's been shown even women with lean body image, you get an idea in your mind and you see yourself in that way, even though other people don't see that. And weight is a common one. We think of ourselves, first of all, it's like it's not even your body once the baby delivers. You're so, it takes a while to get used to the new contour, the new shape, and what you're going to do about changing that. But sometimes that takes a while to make those changes because nothing happens overnight or even, within a couple months. So then vaginal dryness, pain, difficult orgasm, all those things are affected by the hormone changes, and whether or not you're breastfeeding, whether or not whatever you chose for contraception, if you did, so many things can affect that. Then vaginal laxity is a big concern. We stretch way out to let that baby come through a very small area, and it's amazing how well it all comes back together. But there are some things we can do to enhance that, and then some people get really upset about the changes. They maybe have decreased sensation because the vagina just stretched a little bit more and didn't come quite all the way back to that tight, tensile, fibromuscular unit that they knew before. One woman had kind of a sense of humor. She said to me once, I'm just so shocked at how small my husband's penis has gotten since I delivered the baby. So it's kind of a funny way to look at it. But there are things we can do, and I'm going to tell you a little about that. We also have to contend with some irregular bleeding. First of all, bleeding right after the delivery for a while, then it's a while till your period comes back in any typical form if you're breastfeeding. And you can have breakthrough spotting and unexpected bleeding, which is kind of always annoying. And then loss of desire. It's so hard to shift our focus from, partner to then new baby who's so needy. And so we need to be really intentional about incorporating, providing ourselves to our partners as well. 89% of women resume sexual activity kind of like normal within that 6-month span of time. But what's interesting is most of them say it's still not like it used to be. I mean, they kind of accept the new normal, they kind of learn to embrace it, and they move forward together. But when you really question them, they realize things have changed, but we're okay with it. It's the small percentage of people who don't adapt that we need to really work with. So, when is it a sexual disorder? At 6 to 12 months postpartum. The two most common things that we see present that persist as a problem. Of course, the first one, loss of desire, and the second one is difficult orgasm. At 12 months, most women are back to thinking, okay, my sex life is all right, I'm back on track, not having concerns. 5% even think it's better than it was. But it's these 12% that say it's worse and it's never going to be okay again. That's who we need to work with. We do have some red flags that kind of make sense. Some predictors of problems that we can kind of plan early intervention on is those that aren't sexually active during the first trimester, when it's typically still pretty good. In fact, usually women have increased libido or increased orgasms because of that pelvic congestion, all that blood flow that gets drawn there, and you don't have the large uterus yet to be uncomfortable. Another one is maternal age greater than 35, or if there was a history of painful sex before pregnancy started. Now, couples who have dealt with infertility kind of often meet all three of those criteria. So we know infertility creates a huge freight train of momentum. You finally get pregnant, and that's, a glorious thing. But it's not over yet. We need to see this all the way through and make sure things are functioning well afterward. And this is the frustrating thing, because too often OBGYNs, they have you come back at the 6-week point, and that's kind of the conclusion of that pregnancy as far as their charting goes and their package deal goes, with insurance. All of that kind of ends at the 6-week point. And so then you're kind of told, okay, everything's healed up, everything's great, green light, live long and prosper, and see you in a year for your well woman, if you're even doing that anymore, because now we give women the idea that we don't even want to do well woman exams on them every year, which is another whole topic. But they need to be told at that 6-week visit at least, asked about how is your sexual relationship going, and then told if things don't get better by 6 months, or if you're having concerns, come back, because there's things we can do. Because women often don't know who to talk to. They think, they didn't say anything about it all this time, maybe they don't know. The way I look at it is, as gynecologists, we are kind of the guardians of those organs. If not us, who is going to help with that? So I always encourage lots of discussion, ask lots of questions, and you should expect that of your doctor too, or your nurse practitioner or midwife. They should be willing to answer those questions or get help for you. So body image, just some normalizing things. Weight can take up to a year to normalize, or even longer, depending on what kind of contraception you're using, or whether or not you're breastfeeding. Hair loss can be really discouraging. You lose a bunch of hair all at once due to that drop in estrogen. It kind of signals the hair follicles to drop the hair. And so things you can do for that are, staying on the prenatal vitamins, or there's a really good hair nutraceutical that I like called Nutrafol, where they've formulated just all natural antioxidants and minerals and just natural things like that to really deal with all the potential causes of unhealthy hair breaking and stuff. And so that's a really good resource. And then collagen, you can get, really good quality powdered collagen powder and, throw a couple teaspoons of that in your, smoothie or something every day, and that's really good for your joints, your hair, your nails, skin. Stretch marks and C-section scar both fade over 6 to 12 months. So I like to reframe that as embracing that as, kind of your badge of honor, of like turning, shifting into that mother archetype. And look what your body did, transforming and producing this new little human. So it helps to reframe that and for your partner to, touch it, admire it, adore it because of what it brought to the family, and not see it as a ugly mark, but as, a beautiful thing that helped create this baby. And then there are vaginal changes, and I'll talk about those now. Pelvic floor health is important, and it's hard because we don't see our pelvic floor. We can't, really tell that well when we're flexing it. We can kind of, but it's really, they always say stop your urine stream and that's your pelvic floor. Except that's not really good to focus on avoiding dysfunction for yourself. I have a better way of identifying your pelvic floor, and it happens to be during intercourse. So if you have a male partner and you're having penetrative intercourse, so I encourage, to start with, this is especially in the beginning, he can insert the penis, the erect penis, into the vagina, and he is going to be the best judge of being able to tell how well or how firm you're clamping down your pelvic floor muscles around him. And it's a real good way to judge. He can feel it, you can feel it, and it's easier when you can flex those muscles around something. It's much easier to do that than just like sitting there with nothing and going, am I doing it right? I mean, when I check women in the office, it's like 8 out of 10 think they're flexing the pelvic floor muscles, but they're really flexing their abs or their thighs or, some combination, and nothing in the pelvic floor is moving. So it's really something that your doctor or midwife, nurse practitioners should be teaching you during a regular exam, because then we can give that feedback till you do it right. But don't lose the opportunity to have your partner help you with this too and learn. And then also he can tell if you're getting stronger as you're getting stronger, and it's getting more effective that way. Also, I like this little pelvic floor training device. This one's called the Vibrance. What I like about it is that it's an aid that it's a little device with a handle, and it has 3 sleeves that are increasing stiffness. And the idea is you start with just the basic unit, and when you clamp down around it correctly, it'll vibrate. So that gives you your feedback. And then when you get good at that, you use the next stiff sleeve, and that makes it a little harder, but finally you can make that vibrate. And so you go on through, and it has little audible beeps that put you through the paces of short little flexings and long holdings. So using that for about 6 weeks can really make a big improvement and strengthen your pelvic floor muscles. And then you can practice doing those same kind of maneuvers on the partner too. So breastfeeding, we know the hormonal changes with breastfeeding are huge. That low estradiol, low testosterone, and high prolactin state can really just dry up the moisture, also dry up the lubrication. But some women have, some increased eroticism. Sometimes they feel weird about it, like why does it kind of turn me on during breastfeeding? Well, it's really that release of oxytocin from the limbic part of the brain. However, that attachment and bonding feeling that that elicits is often mostly directed at the baby and not so much at the partner. So you have to be intentional at sharing that with your partner and not only lavishing the baby with it. We know that breastfeeding past 6 months can be a risk factor for arousal disorder, for lower sexual satisfaction. Not to say we shouldn't breastfeed as long as we want to. It's just be aware of that we have to compensate for that and be more intentional about our relationship, because it does put us at a bit of a disadvantage hormonally and neurochemically. This is just a picture to describe some important components that people often don't know about. Where the arrows are pointing are known as the vestibular glands, or the top one there is the Skene's gland or periurethral gland. It's right next to the urethral opening. And then the lower one there is the Bartholin gland opening. And we have them on each side. And why they're notable is because those being inflamed and sore are the number one cause of pain, sexual pain in young women. Typically, it's from birth control pill use in the past, but pregnancy is a big killer of our androgen levels. And then stress as well. So often when you have all of these things, maybe you use the pill right up until you got pregnant, and now you're pregnant, and it's all stressful. Now you have like 3 elements of that are keeping your own body's testosterone production super low. When that happens, these glands become sore, inflamed, and red. They're loaded with androgen receptors. And women always just perceive that as, every time I have sex, I get a yeast infection. I hear that all the time. It's really not a yeast infection. It's just because that's the only thing we know causes those symptoms: scratchy, sore, itchy, uncomfortable. And so then it'll get better because we stop having sex, or we get some antifungal cream to kind of lubricate it. But then next time we have sex again, it happens. So it's typically not getting a yeast infection every time you have sex. It's this underlying vulvar vestibulitis that we can typically treat and make it go away within 2 to 3 months. So I like to talk about it because women walk around with this or have this in their relationship sometimes for years or decades, not realizing something can be done. Sexual pain postpartum, like I said, hormonally mediated vulvar vestibulitis is like the most common thing. Then you can have some other less common things, of course. If there was pain prior to pregnancy, it's probably coming back afterward. And then nerve pain from childbirth or trauma, those can get set up from either lacerations or being sewn tighter than needed to be, or just stretching or forcip injuries. I mean, just depends on the individual situation. But the point is, there's a lot that we can often do about that. We just have to be able to intervene soon. This is a picture of an example of that vulvar vestibulitis where those gland openings are all flared up. All I have to do during an exam is I get my little swab wet so that it won't be like a frictiony, uncomfortable thing. It's just wet, like a wet Q-tip. But I touch those areas, and it should just feel like a little cold, wet Q-tip is giving pressure. But instead, it feels like I'm stabbing it with a scalpel. That's how tender it is. So women are always surprised by that. And then again, that can usually be reduced within a month by using some compounded testosterone cream that I prescribe. And then the statistics are, within 3 months, 95% of those cases are completely resolved. So it's important to know about. That kind of situation can trigger a deeper problem called hypertonic pelvic floor, where the pelvic floor, our bodies try to protect us. And when we keep getting pain, our bodies compensate. And so they try to spasm and tighten and clench to keep the pain away. So when you feel like your husband is hitting something in your vagina, it's often not your cervix. It's because your vestibular glands caused pain and that triggered your pelvic floor to clench. So that strong network of muscles forms a big wall and is very strong and clenches and just really reduces the volume in the vagina. And it gives the sensation of hitting into something. And that's very tender because hitting into those tender, tense muscles cause even worse spasm. That can be unraveled as well with pelvic floor physical therapy, which I know there were some talks on that earlier. But the point is we need to work together to first reduce or eliminate that superficial pain that's triggering, and then unravel the deeper pain and teach those muscles how to remodulate and relax. So in that case, Kegel type exercises would not be good because you're already too tight. We have to teach you how to relearn the relaxation side of things. So that's part of that myth that everybody needs to be doing Kegel exercises could be wrong. It could actually be hurting things. That's why you need help from somebody who can help you sort out what you really do need. This is just a little diagram I made to show that mechanism because it's so common, and women wonder, well, how can birth control pills cause this? I'm not taking them now. And it's just the point that having taken them in the past can set you up for this because your body never corrected it. It can be directly while you're taking them because of suppression of your own hormone production. Your ovaries are kind of put to sleep with the pill, or in that indirect way that I just described, causing the vestibular pain, which causes the high tone pelvic floor muscles, which then makes you not want to have sex because there's no pleasure in something that's going to be hurting. So we have to unravel that. Postpartum arousal and desire disorder really means when really the idea of sex completely leaves your thoughts and fantasies, under all situations. You can't even think of your favorite movie star in a sexual way anymore. I mean, it's like completely turned off. And it has to last 6 months and cause you distress, and typically your partner distress. And so it's not due to one of these other things that we can alter, like situational problems, chronic disease, depression, meds. If you had to start a medication like an SSRI to help, postpartum blues, that can take away your orgasm and can decrease your desire. So it's important to know that. So early interventions at home, I just like to give some recommendations on, they're kind of obvious, but it's surprising how often I have to remind women to do these things. Avoid just becoming roommates. You have to be intentional about your relationship and yourself. Women so seldom make time for their own self-care. We put ourselves on the back burner and we're nurturing everybody else. But we need to have attention too, otherwise we're not going to be a suitable partner and we're not going to be able to have anything left in our cup to give eventually. It helps to replace thoughts of the infant and infant care and what needs to be done. Instead, replace those thoughts intentionally with thoughts of your partner. Maybe go back to when you first got together and some great times you had. Put those things, because if we say we're not going to think about something, just doing that means we're thinking about it. And so we can't just say, I'm not going to think about the baby, because we're just thinking about the baby. You have to replace that thought with something else and focus on that. All forms of intimacy. It doesn't always have to be penetration. And communicating. This is another thing I do a lot with my sexuality counseling. In fact, I just was talking to a woman this week who was lamenting. It wasn't about pregnancy. She was postmenopausal, but she had just had a hysteroscopy for a polyp in her uterus. And she was so angry with her husband. And I said, what did he do? And she said, well, I told him, it's just an outpatient surgery. I can just take an Uber there. It's not a big deal. I'm a big girl. And he said, okay, I guess I'll go to work then. Wrong. But she said, well, he should have known. I was going under anesthesia. Why would he let me do that? Why would he let me take an Uber to the hospital and not be there? And I said, because you told him you were okay. You have to ask for what you want and say what you need, because you can't just get mad when they don't follow the dots to what you were expecting. But we know this happens all the time with all of us. So just more clarification, more discussing of feelings. It helps to really come together and talk about how we can accomplish this goal. Like say, I just need to have some more sleep. I'm so tired. You need to have at least, a few nights during the week where you get some, 7 hours of sleep. So negotiate. Who could help you? How could he do it? How it could work? Instead of just assuming he should know this and he's a jerk for not helping figure this out. We have to vocalize the problems and then negotiate how we could accomplish it. And then if you just can't get on top of your mood, you need to get help with that. We have many ways to help reel that in, because often it won't just get better on its own. And you'll feel worse and worse out of control until you get help. This is an interesting little stat. What do you do about lack of privacy? And it turns out most couples end up having sex, with the baby on the bed, or at least in the room, because if not, you're never going to. And it turns out, the authorities all seem to think it's fine. It doesn't scar the baby. It's helpful. You have to adapt how you can. And 60% are still, having sex at 1 year with the baby in proximity. But they just learn to roll with it, and babies are good sleepers, and, it's okay. But it's important to communicate with each other about what feels normal and what feels right. Orgasmic disorder is not so common, and dealing with postpartum, it means that it was fine before pregnancy and even during pregnancy, and then something happened after pregnancy that now you can't manage it. Those are less common, and it has to be present at least 75% of the time, or in most all situations. It can be caused by so many different things. Often it's just fatigue and stress. And so there's some testing that I do that can really help sort that out. Lifestyle changes are helpful, and we need to take time and collaborate with these. Exercising increases desire, so if you can have a date night with your partner where you exercise first, that's going to stimulate your autonomic nervous system and make orgasm easier and improve desire. That's been shown with research. Reducing stress and anxiety is so important. Meditation and mindfulness and staying present is really the key. Vibrators have really become mainstream, and they're not for everybody, but I consider it a tool to help redevelop and enhance a reflex that may be compromised due to hormone changes. It's not like you're going to replace your partner with a vibrator, but nothing works as good as that vibrator for eliciting that nerve response and helping your body to remember, oh, that's how we did it. So just to get back in the groove, it can be really helpful. And there's been research done on this too, that women typically need a deep rumbly vibe, not a tinny, made in Taiwan, high-pitched one. Isn't going to do the job. When women tell me, I tried the vibrator and it didn't work, I always say, what kind did you try? And it's always one of these little pocket ones that, is little cheap plastic and has a really high vibration. You need to get a more bass, rumbly tone to really bring those pelvic nerves into proximity with that. And examples of that would be the old standard is the Hitachi Magic Wand. It's a bigger handheld unit that provides a real deep, rumbly vibe. And then a more updated type that has really versatile, you can dial up the intensity and put it on, I think, 14 different modes. And it's waterproof, is the Smart Wand by Lalo. Those are two really good, reliable ones that can help. And the Lalo one comes in a few different colors, too. So it's fun. A lot of times women don't know really what their clitoral anatomy is. It's really so much more than that tip of the iceberg that's just at the top of the vulva. Really, the clitoral complex extends subterranean under the labia, all the way down the full length, and then inward surrounding the vagina. So when that clitoral complex gets aroused and engorged, the whole thing reacts with each other. So vagina is really tied with clitoris. They all kind of work in a complex because they're all engorged and brought into the same, proximity like a unit. So sexual medicine, just a little bit about that. Some of the stuff I do that's unique, I do a digital technology guided vulvoscopy. The bottom line of this is that on a digital tablet like an iPad, I often use that so that you can see your anatomy and I can totally explain to you what's going on. You can see those vestibular glands, all inflamed, or you can see where that tear is that just isn't healing right. And so then you know exactly what's going on and you can connect with it and heal it. Or you can know exactly where I want you to put this cream. And your partner can be in there and see that too on the iPad. It's just so, high definition. And you can even take screenshots if you want to. I do a lot of different medical assessments depending on what the problem is. But this is why I say that a lot of people don't know all that's possible. And we can look at blood flow, nerves, strength, pelvic floor strength, labs, hormones. And so there's so much that I put together when I make a program for someone. And then we can't leave out the psychological part of it. We have to talk about the relationship, how foreplay goes. So often orgasm isn't managed for the woman. Women are often surprised to find that, intercourse, which is, we mostly consider that's the main entree of sexual activity, right? But really, it's only the most reliable path to orgasm for men. It's not the most reliable path to orgasm for women. Women, only less than 5% of women achieve an orgasm with only vaginal penile penetration. So women need some direct clitoral stimulation too. One strategy is to allow the female to have an orgasm first. It relaxes the pelvic floor. It starts flooding her with all those feel-good bonding hormones, and then move on to intercourse. So however the foreplay has to happen, it's really not so much foreplay because it can be main play for the woman. So both need to be addressed and figured out what works for you. Sexuality counseling, we look at focused goals. I help with really this mind-body connection. And another big research area of mine is how to intentionally manipulate your brain chemistry so that you can increase your dopamine output by doing intentional things, thinking a certain way, behaving a certain way, and doing some activities with your partner. And of course, I refer and collaborate with sex therapists often because I'm not a PhD sex therapist. I'm an MD sexuality counselor, so I know my limitations, and I defer to my colleague therapists when it comes to the more complicated relational issues or mood disorders or all of those psychology things. So it's important to know we need to talk about sex. We need to not be afraid of asking questions. We need to seek help from people who know how to help us. And it's as mainstream and normal as any other medical or psychological concern women have. So we need to take it out of the closet, talk about it, ask about it. And as far as professionals go, when I talk to them, I tell them the same thing. There's deplorable statistics that less than half of the time do healthcare providers for women even bring up issues or questions about sexual satisfaction. We need to do better for that. And what I like to say is we have 3 Ps of women's health care.